informatics seminar. We'll get started. And just so you know, a lot of people watch these live streaming. So that's why sometimes there's not as many people in the audience. But I know I watched John Hurdle's last time live streaming because I couldn't get over in time. But we're really happy today to welcome Tamara Moores as our speaker. And I heard about Tamara last year because I heard, oh, there's this fellow in emergency medicine who's going to do the clinical fellowship in informatics, or, become board certified in informatics. So I'm like, what? I haven't heard of her. We need to meet her. So Denise Baudouin went over and met with her and talked with her, and she ended up coming. She's taking several of our classes right now, and then we'll take the board certification test eventually. So we're really happy to have her come, and she's going to talk about the work she did as a resident, and maybe she can also give us a little bit of a introduction of her interest in informatics and what she wants to do in the future.
Hi, can you hear me? No, I think I muted it. Let's see. Can you hear me now? Okay, I'm gonna turn it up a little. Perfect. Oh, that's loud. That's good. All right. So what we're gonna do is we're gonna make a point. Sorry, got sabotaged by that PowerPoint slide. Okay. All right, hi, my name is Tamara Moores. I am an emergency medicine physician here at the University of Utah. I completed my emergency medicine residency here at Utah in June of this year, and I'm currently enrolled in the certificate program with our Department of Biomedical Informatics, and I am so excited to be here. When I was first asked to give this conference, I was honestly shocked and honored, of course. I suppose I was shocked because I feel like such a beginner in the field of biomedical informatics. It's true because I actually am a really big beginner. I've never studied computer science. I'm not a programmer. And this lecture is not about someone who's skilled in coding or necessarily app design, but about a very simple person who still managed to fundamentally change her work environment using straightforward, free, universal tools, and with using a lot of enthusiasm. So again, my name is Tamara Moores, and today we're going to talk about how I implemented a full system change, or how I made a lot of doctors do what I told them to do. The focus of the discussion is not necessarily the nuts and bolts, but to show a small example of how you can truly change your own work environment with enthusiasm and the courage to see things a little bit differently. So the focus initially of this discussion and overview is going to be who I am. I'm Tamara. Why learning as a resident physician is extremely difficult. Why it's important. What I did to make learning better. And then the lessons I learned from this implementation. I just want to review the stages of resident education, physician education, so you can better understand the challenges of subspecialty education. So it might be a little bit boring initially, but as a medical student, you start off after an undergraduate degree. Traditionally, medical school starts with 2 years in the classroom. The subjects of classroom study include anatomy, physiology, biochemistry, pathology, microbiology, physical diagnosis, all of that, all of those little books right there, cramming into your head. And patient contact is typically limited to shadowing, trying not to make too much noise, and trying not to say something dumb. The next 2 years is spent working clinically. 3rd and 4th year medical students wear the short white coat. They interview patients, evaluate patients, very small amount of patients. Then they will present those patients to resident physicians or attending physicians. Nothing a medical student ever does is unsupervised, theoretically, and a medical student cannot enter orders without another physician looking at them. Then these people graduate from medical school as physicians, as MDs. Short white coat. It's sad. It's a short white coat of shame, really. Okay. So Once you're done with that, then you become an MD. But most folks will say real medical education starts after you graduate from medical school with your MD. That's why we have residencies. A resident physician has an MD, but they're still practicing under the supervision of an attending physician. Resident physicians receive a very small salary. They typically work 60 to 80 hours a week. They're required to participate in didactic education every week in the form of conference. They have long white coats, and these people are busy. They are directly involved in patient care. Their decisions and thought processes are still guided by older, seasoned physicians known as an attending. These people are very, very busy. They are bone tired. They are puked on by their patients, and they still have to have awesome education. And this time period, as a resident physician, when you are running around the hospital with little food, little sleep, and you still have to learn, that is the focus where my system was implemented. The challenge was simple. How do we optimize education during a time period when people are working way more than they're studying? They're still theoretically studying while they're working. When I arrived to the University of Utah in 2012 as an intern, the bottom of the totem pole, our residency program followed a more traditional format of education. Now, we're required by the National Resident Accreditation, whatever, to provide lecture time. So residency education in a nutshell when I first arrived. Every Wednesday, about 30 resident physicians and 10 to 20 attending physicians go sometimes even to this room. They sit in a room like this for 5 hours, listening to someone do a PowerPoint and listening to topics. The PowerPoint files were later uploaded to a very difficult to access website. The residents would then leave and go back to their busy work schedule. Typical shift for a resident physician in the ER, it has been demonstrated that you're interrupted every 30 seconds as a resident physician. How do you teach in this environment? You care for high volumes of patients, typically seeing at least 20 patients in a 7-hour period. You're simultaneously managing 10 to 15 patients while you just graduated from medical school a month ago. All of your patients are very sick all at once. And while you have attending physicians who are also instructed to help you, to teach you, to facilitate your education, they're just as busy making sure you don't mess up as well. It is busy. And the opportunity to pensively reflect upon lecture time where you sat 7 days ago and listened to some PowerPoint are minimal. And despite the fact that these 5 hours of lectures are awesome, yeah, we love people put time into them, people prepare for them. Those slides were great. They really were bulleted nicely. No one's going back and reviewing that information. So 50 physician audience never reviewing that information again. So when I arrived as an intern, the simple fact of the matter was that no one was looking at the PowerPoints or lectures or information after the fact because it's too busy on shift. First learning point that I can give to you. If you do not make an educational reference that populates on a smart device within 20 seconds or less, physicians in the emergency department will not use it. I'm going to say it again. You need to have a reference that populates within 20 seconds or less. Because once you hit that 30-second mark, I'm already interrupted. I'm already running to the next room. I need something that populates fast. And we needed something that went to all of these physicians at once. So my challenge, how do we distribute education, change it from a simple audio format where you sit, to something that is clean, visible, easily referenceable, and automatically updates and populates on every one of my 50 physician smart devices every single time I change something on it. The second part of my challenge was to use formats that would extend beyond simple academic physicians to a general physician population who are not necessarily attached to the university. The emergency medicine residency here is the only emergency medicine residency in Utah. That means we are seen as leaders in populations of thousands of physicians who are alone in solo hospitals all over the state and every town. We have a collegial mandate to interact, facilitate, and improve the access of these physicians to our lectures lecturers and our resident physicians to those seasoned physicians who are rural. So my 3 challenges. Change traditional lecture series into something that people can reference at work into 20 seconds or less. Increase the access of rural physicians to our lecture series, and increase the conversation between rural physicians and university physicians in a protected online community. The 4th mandate was to do it for free because we don't have any money. So, the first challenge, change the lecture series into something that works. I mean, this has been done, right? It's file storage. It's not that hard. There's Google Drive. There's Dropbox. There's Box for the university. There's Canvas. There's ways of file storage. One that I landed upon after much debate is Evernote. I'm actually using Evernote to present right now as well. So, lucky you. I'm going to show you what we made. The problem with overall resident education and sourcing protocols is that if you try to source it through the EMR in the hospital, it's never going to populate fast enough, and it's never going to handle all the lecture materials that you do. So what I did, I changed every single lecture that we did into an Evernote file that would auto-populate on every single person's smart device. Every time I added a file, it would update to this person's smart device. So every single resident physician has every single lecture, every single protocol, every single pertinent journal article, and they don't actually have to do anything for it to push to their device. So what happens is every time someone would do a lecture, for example, let's see, pneumonia update by Dr. Stacy Johnson, all of these facts that people want to reference are automatically populated here, and that's on 50 physician smart devices. And every time I add an article to it, it populates without them knowing it, which is very helpful, so they don't have to do any work. All of our hospital protocols for acute management of significant emergencies auto-populate on their smart devices. So this is our protocol for a massive pulmonary embolism algorithm. And at one point in the hospital a year and a half ago, our program was the only one to have this protocol because the pulse net was down. And a patient that coded, I was able to pull up this protocol in 10 seconds, give the patient the medication, the patient returned to spontaneous circulation and lived. So that was the first part of our system. Now I'm going over a little bit quickly. Are there any questions about this particular part?
Can you speak a little more about the technical?
Yep.
What did it take to do that? And how did you do it?
The great part about the technical is that it was extremely simple for someone who's simple like me. It's, of course, you can make an app, you can write a file, you can do all of these things to create your own proprietary sourcing information, but I'm not that type of person. So Evernote is a file storage system that automatically populates on any particular smart device, Android, iOS, or website. And so what it basically entails is I would create a new notebook, lecture. And then you're able to add notes. And visually, you can add any PowerPoint, PDFs, pertinent slides. Then we would send these notes to the chiefs and the lecturers that had already given them, make sure that they're independently reviewed. And then we share that notebook with the entire physician staff. Evernote is free. It doesn't require any more independent thought from my physician population than a login and a password. And that's why it worked for us. The problem with most of the references that get created in a hospital system in an EMR is that you have to log in to an independent protected website, and then you have to pull it from Pulse, and then it may not be updated. Whereas if you use something like Evernote, which doesn't have any patient protected information, you're able to share large volumes of data in a very simple way. The more clicks and the more passwords you have for my physician population, the more they lose interest. Anytime you have probably more than 3 taps, they won't do what I tell them to do. So that's why I use this. It's not a perfect system. It's not. And the interesting thing about what we did is really, I'm going to quote General Patton, a good plan violently executed now is better than a perfect plan next week.
What do you measure
What do I measure?
when you deploy this?
What did I measure?
Yeah.
For, oh,
Because
to,
you have to know something about what you did.
so I deployed a survey initially asking about what people use for quick on-site and shift references. And so I evaluated how they were using the system that was in place. After evaluating the survey, then I had maybe 5 or 6 meetings with the whole group to figure out what the barriers were to access and what they would want in a system to create quick, easy references. I then created a small focus group with a variety of different types, like Google Drive, Dropbox, and decided after some effort that Evernote was the best modality for our group at the time. And now I am currently employing a survey to evaluate the usability, and we're considering upgrading or switching to a different system now. Most of the survey respondents were using simple reference modalities such as UpToDate, which is a third-party website, and not necessarily emergency medicine specific, nor monitor regulated by the attending physicians here. The interesting thing about education is that regardless of how interconnected and networked you are, education still comes down to a face-to-face conversation with a small group of motivated individuals. If you don't have that small group of motivated individuals to create a community, then you're not as involved as you should be.
So you are doing a pre-post evaluation.
Yes.
On qualitative.
Yep. It's hard to get objective, quantified data, so much of it is more of a conversation survey mode.
But you don't use a control group or anything?
No. Mm-mm.
So, quickly flash kind of halfway up there
Yep.
that you'd expect from
Uh-huh.
Now, is that, is the document that pulled up, is that static, or is that actually
Great question. Yeah.
gets updated?
Yes.
Where does,
It is static in this system, which is a restraint of it. But Pulse is also static, and they upload Word documents and PDFs as well. So honestly, the ideal system is to make Pulse super accessible and easy to use. But that hasn't happened yet, and so we find workarounds. And I admit this is a workaround. Yeah. That's the first part. It's not the most exciting part, really. The second part of the system that was requested by my leadership was a system to not just live stream conference, but to be able to webcast people in and increase that access of the rural physicians to our series. So currently you guys are live streaming this conference. And it's very helpful and very useful. And a lot of departments do this. Internal medicine live streams their conferences. OB-GYN live streams their conferences. The hitch with this is that anyone who streams in isn't going to be able to have verbal interaction with the lecturer or with the folks that listen to you as well. And although we still want to provide CME to our recipients who are in Tooele, who are in Wyoming, who are in our affiliates in India, we also want to hear what they have to say as well. So my department chair asked me to find a way to provide CME to those folks who are academic physicians who might not be at lecture, but to also create a lateral conversation between the residents during lectures themselves. And we couldn't really use Canvas because not every one of our learners has a university access. And we also needed to do it for free. So what we did was we changed our modality to live streaming on something different. All right. So what they were asking me to create is a learning management system that was universally accessible, that had no concern for patient privacy, that was updatable, and that would provide residents the opportunity to exchange information in a protected way. So what I did was I evaluated maybe like 10 or 12 different learning management systems, considering all the ones that are available in Google Classroom, Canvas, and landed on something that's called Schoology. So this is a learning management system that's also free, easily accessible on all Android and iOS platforms. And it is password protected, so only the learners that I choose are able to live stream in. And what we do is we post a unlisted Google Hangout on air every week with CME conference access codes. And what happens is that we have now live streamed our events to India, to someone that was flying on a plane. And every time that we live stream an event, it's automatically cataloged so folks can look at it afterwards and reference what happened before. Currently, we have attendings and residents posting lectures back and forth, posting articles back and forth. And so when you're sitting in conference right now, if you had a great thought and you wanted to post an article related to what I'm saying, you'd post it on our system. Then you could say something else back. And all of you guys would be able to have a much more dynamic conversation during what could be a boring lecture. So that is what we have created for the University of Utah. Now we've extended it to all the rural physicians in the area. And again, whenever we post conference summaries or protocols, then we post them here as well and they can access them.
What's it called?
It's called Schoology. There's always a debate on how to pronounce it. So I think it's pronounced Schoology. But there's actually even a video about how to pronounce it, and everyone says Schoology. So, learning management systems are fascinating because you work within a system that's given to you, right? But if you look at your learner population, they may not necessarily be what's best in the long term, or may not necessarily give you the most up-to-date access if you want to extend your learning population beyond your simple university. And so this is what we have trialed out. And it's not perfect. I'm not saying anything that we've made is perfect, but the fact that we have more learners who are able to watch our lectures, who are able to interact and receive CME necessarily if they're not here, and improve our resident education is something that people are very excited about. We presented it at our state Utah ACEP, American College of Emergency Physician meeting 2 weeks ago. And participation is booming, which is what you want for education. And the nice thing about it is every time a rural physician is able to interact with our residents, our resident education, who are busy, who are hectic, who are trying to understand how to be an independent practicing physician, our resident physician gets better education.
Do you know what kind of bandwidth you need?
This one. I just do it over Wi-Fi here.
No, on the receiving end.
Oh, on the receiving end? You know what? I haven't had any issues, so I haven't addressed that. I haven't heard anyone being unable to stream. And as long as you do it through an unlisted Hangout on air, it's not searchable, so it's a closed conversation. And then we've streamed in lecturers from New York, leaders in the area, and projected them right here. And so it just really sort of expands that emergency medicine education to something that's beyond a simple sit and listen scenario.
Do either of those tools have ways to capture quantitative information, like how many times
Yep.
it has been viewed?
Uh-huh. Yep.
Have you done that yet?
I have. So initially, there was me and one viewer in San Francisco. One of the attendings is very excited. Typically, at this point, we are getting about 6 to 7 viewers a day. And then the resident access is increasing as well. But I've been looking at the viewing stats recently.
How about Evernote? Is
No.
that-
Yeah.
That'd be.
It would be, yeah. I'm honest, and so we're currently having focus meetings right now if we want to stick with Evernote or switch to something that's different. So I don't know, but that's why it's better to have a poor plan that is implemented and works, and then to reassess, rather than to wait for a year and a half and implement the absolute perfect one. And that's what I've learned with education overall and iterations. Things change, technology changes, and you have to change with it.
So you use it very much an
Yeah.
agile development model.
Yeah. Yeah, you see how the recipients respond and go from there. It's a small size overall, 50 docs. So you're able to be more fluid with it. But Oh, no, you're okay. The overall point is to change your lecture format into something that also increases repetition. Is if you only see that information once, then when you're on shift and trying to remember what the intralipid dosing for lidocaine toxicity is because you just injected that hip, if you don't see it multiple times, you forgot to write it down initially, then you have to go back and look it up somewhere on some protocol somewhere, which takes you another 5 minutes, which is not helpful. But if you're able to see it 3 times again, then it sinks into your brain. There's too much information for a physician or any learner to remember everything on the first go. And so the question is, how do you get information into your learners as easy as when they tap on that Facebook page, which is my goal, basically. Oh yeah, totally. I mean, that's the ideal electronic medical record in an academic facility would teach the residents as they enter patient data and orders. Education in a hospital system doesn't always seem to be the top priority. It's very difficult to integrate that, but that would be the ideal system.
I think like in my cases was based like very similar system was based on primary
Yeah,
education
yeah.
materials and we integrated from that and it was like very well accepted by physicians.
Oh yeah. Anything that makes your job faster and easier, a physician would accept.
And you know here like in the department we have your that is working with the standard that can help in the integration process.
Yeah.
Clinical system and knowledge.
I think that's the ideal system. It does take a lot of time and effort to implement it. Yeah.
Tamara and I think Tracy, are you working on the
Yes,
pioneer project?
we're working on trying to the quantum unfold
Yeah.
and injecting like material.
Mhm.
Yeah, because we're trying to find a way to make a space so that any updates to guidelines or however you want to call them, if there's an update, guidelines will always go to whatever is the most recent.
Exactly. Yeah,
We need that.
we do.
And it's not just that though, it's that you don't go to Pulse to get your guidelines.
Yeah.
To describe it to them, it might be relevant.
Yes, the idea is just to use like the context information that the EHR
Mhm.
or the system that the user is using at this moment, for example, the kind of provider, the kind of the patient characteristics, like the problems or the diagnosis that patient problem with, and just show the information in like another manner, like more usage of that user.
Totally.
More context oriented, and if you can log like what is user really not give like credit, like credit,
Mhm. Yeah,
that
I agree. That's why I'm studying informatics. Because I think that is absolutely the perfect system. There's no reason to make two, simultaneous systems that goal is the same: optimize patient care and resident education. So.
I would disagree with that because there are certain parts of the traditional EMR that are heavily regulated.
Yeah.
And evolution of a very heavily regulated system is very difficult in the agile development cycle.
Yeah.
So it's conceivable that the best way to provide information to physicians is to do a more. And you have agile development in the areas that are not heavily regulated and areas. And some of the things that you need to do in an EMR require heavy journaling entries and things like that you don't require in the system.
And I agree, and that's why we made a dual system. And the problem with putting things into EMR is, number one, you have administrators who care about more broad things like billing and JCO requirements and politics.
But journaling, if you
Yeah.
any EMI. And of course, you need to do journaling in an EMI.
Right.
And
Yeah.
that's very, very slow.
Whereas a system that's quick on its feet allows for that lateral dialogue between, ideally, our audience would be 200 to 300 physicians in a closed, protected online community, really increases that education, because education is conversation, which is what we were trying to facilitate.
What I think that what you need is that the EMI needs to have IPA to put web services that then you can develop independently.
That makes a lot of sense.
That's what
Mhm. Yeah.
But the journaling is a big problem.
Yeah. Exciting times.
Yeah, I think just like you're leveraging open source apps,
Yes,
there are open source platforms behind the scenes
right,
that you'll learn about that can be leveraged to deliver knowledge.
exactly.
And there's some like standard-based like info that today are supported by Untitled Chapter.
Yeah.
Useful.
Education is interesting, though, especially for resident education, because there's so much proprietary. Emergency is different than internal medicine, which is different than neurosurgery. And so when you create clinical decision support and info buttons within an EMR, most subspecialties still want to have their bend on it a little bit. And so having an opportunity for that online community to still talk is powerful in a resident education where they're focused on developing something that's quite unique to that specific physician group. Short but sweet, that's all I got. Yeah. Yes,
You index your system?
no. The content, the content, I mean, the content, it's
searchable.
It is, yes, it is searchable, yes. Using everything in the Evernote file is searchable, including pictures of text, including the titles.
You do the indexing.
Evernote does it for me.
Have you seen behind?
I have no idea, that's why I'm simple.
Probably you can do like that, but
No, they may have locally in the backend.
Yeah,
I don't know.
but I know that all the photos that I take, the text in the photos are searchable.
So they probably have Lucene in the
Yeah,
backend.
yeah,
But
yeah.
that's built in for you.
Yep, it is built in. So anytime anyone wants to find a note on my TPA,
Yeah.
just type in TPA. So,
Well, that's the way we like to do it. Sometimes they try to put it
yep.
free. So how they run this for free? I mean, they know free that.
They incentivize their users to upgrade to a premium package. So if you want to use extra buttons and whirls, you pay $50 a year. We just don't. The same thing with Schoology. If you want to use it for a more robust modality and want to source all of your information on this website,
Do they
Schoology,
mind your data?
probably. But I don't host any of the video content.
Do they extend to certain target advertisements?
No, there's no advertisements.
one of the big issues here is how manage the content, all the content that you are
Yeah,
generating.
5 hours a week.
At the beginning, and I think that was one of the main problems that I was seeing
Uh-huh.
in that platform. Where we were at the beginning, generating and maintaining the content.
Right.
But then you need like a plan and structure to support that.
Right. So now that I've left the university as a resident, I'm no longer in my managerial role. And so that's the most critical time of any system, is handing it off to someone else who's less invested. So the live streaming of conference, the online community, the posting of all those resources is still maintaining. They designated an administrative person rather than a resident when I was doing it for free before. So that part of the system is living, which is super exciting. So all of these posts, everything in terms of posting back and forth and that conversation is still continuing on the, that's my work, on the Schoology site. So they now have an administrative person who posts conference schedules and PDFs and the live stream, and they're invested enough to pay someone to do it now. The creation of the content files on Evernote is not going as well. No one else wants to make them besides me. So
So you like copied these out of the
yeah, they were pretty extensive when I first started. So this is an example of a typical lecture summary for peripheral nerve blocks. So it includes like quick reference facts for lidocaine toxicity, pertinent online blogs and resources, then a summary of the lecture from my written, and then pictures of how to approach every femoral and different peripheral nerve blocks.
And that's done by a human.
It was me.
That needs to be done by a human?
I'm reassessing that. So I started making a more streamlined approach where
The
you,
problem with
yeah.
humans is that are
exactly, yeah. And so I think it's not going to be sustainable by a human. So that's why it hasn't gone on for the past 2 months.
Anybody here have ideas how to take the lecture content without a human trying to do it all?
that you'll see when you get to do it.
Yeah.
You index the lecture notes.
Yeah. I think,
How are you going to get the lecture notes from the person's PDF or PowerPoint?
Oh, there you
into-
go. PDF, you can grab PDF and do it.
You have to put that burden on the lecturer.
No, you can go that's easy. The indexing is.
the problem with SlideShare is that it takes a long time
to
to,
get the quality that you get from human.
yeah. So
If it's good enough, it's good enough.
my streamlined process is now I just put the slides into PDFs, and then I put the pertinent learning points in like one paragraph from the whole lecture, so that way you still have a reference. Uh-huh. Yeah, so the problem with like actually downloading PDFs or slides is that no one likes to read them. And so,
Maybe we should quit giving slides.
yeah, probably.
I'm sure a lot of us have probably read articles about how PowerPoint is
That's why I didn't use PowerPoint for this. I actually never use PowerPoint anymore. Because I think it sucks and limits that conversation that we're having. So, so now what I do is I just switch all the PowerPoints into PDFs and then post what I think are the pertinent summaries. And that can take a human, 5 minutes. Quick hit, start beta blockers within 24 hours. That was the one-liner from the lecture of an hour that I thought was relevant. And then if they want to reference more slides, then they can. That changed a lot from my initial attempts where I thought I could maintain that, which is really hard.
At some point, you will need to add like metadata to these
Yeah.
files.
Mhm.
For example, you will need to know when to update
Yeah.
one of these specific
Well, the nice thing.
files because
Yeah, the nice thing about that is that it's time-stamped, and so folks will know if it's from 2012 or from 2015, every one of these notes. That's a great question. And the interesting thing about creating a local community educational resource is that metadata or online resources where a lot of people look at them are intrinsically better, right? But you can't just learn emergency medicine from an online blog from an educator that's in San Francisco. You still need to learn education and emergency medicine from your attending who's been here for 30 years, who's still very talented and creates excellent content. If we were going to just source metadata, we probably would just go to one of these blogs, like Academic Life and Emergency Medicine, that creates summaries, which uses a combination of social media and Twitter to facilitate that worldwide conversation. This is a lot easier, but we're still a group of people. We still have certification processes. We are still in a lecture content here that creates this conversation of us in Utah. And so biomedical informatics department still creates ways to communicate among ourselves using Canvas. We, as the training environment for a physician, still requires a residency and still requires to optimize education here in Utah. And so we still have to create our own content that's easily
but
accessible.
maybe this can
Yeah.
be like a good platform.
Yeah, we do. So we, yeah. So now a lot of times what we do in terms of to try to flip the classroom, we'll listen to blogs or podcasts from some of these awesome sites before lecture and then just come in and discuss them. Or we'll tell folks to go read stuff on these lectures as well, but we still have to have 80% of lecture time by our own educators.
Regulatory.
Yeah, and I think it's good. It's good to have that conversation, and it's good. Our educators are fantastic. And so my goal is to create accessibility to that lecture material in a work environment that is just as viable and just as well received and accessible as what we have on an online social media. But that's populated from 5 hours of lecture every week by some manner of effort.
If you could change the lecturers,
Yeah.
you could influence the other faculty, what would you want them to do that would be a better educational experience?
Well, that's a question we ask all the time in a residency program. I think a lot of those efforts are changing. The lecture formats already. We do a lot more small groups. We have a lot more discussion. We bring in experts and grill them in a 5-person panel. We do a lot of asynchronous learning. So all of that has changed in our group in the last 3 to 4 years while I've been here. This small part is how I created accessibility to that content. And I think my lecturers are doing an awesome job. I think it'd be nice for folks to create a short summary of what they think are the most salient points every time.
So you don't have to go through all the slides.
Yeah.
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 I would do it.
Yeah, I mean, repetition. So, that's
Okay,
what,
so can we pick your brain while you're here? 'Cause
Yeah.
this is one of the advantages of having you speak, like hearing about the resident experience.
uh-huh.
You know, some of us might have never heard of that, some of us have gone through it, so different levels of background, but what are the big problems in emergency medicine that you think informatics can address in the next decade?
The biggest problem with emergency medicine is the volume of patients and the lack of thinking time. And the fact that most of the systems are difficult to work with in emergency department flow. So in terms of patient volume, there's so many opportunity for errors. So I think clinical decision support is one of the forerunners of how we will improve patient safety in an emergency department. The areas for improvement are limitless, starting from the initial vitals creating clinical alerts all the way to how to facilitate admitting a patient from the hospital, from the ED to the hospital. There are so many opportunities for improving efficiency, flow, and patient safety in informatics in those areas. I'm working on a sepsis hospital protocol right now as the ED lead, where we're trying to create a clinical decision support for activating vital signs at triage and then activating antibiotics within 3 hours, putting reminders into the physician system. And then in terms of improving ED flow overall, I saw an amazing EMR out in New York last year that they rethought how notes were populated. So rather than having a physician note, an RT note, a nursing note, it all goes into one system. And it makes sense. I mean, it's all the same patient encounter, so why shouldn't you just have all the information on one readable note? And then whenever an emergency physician wanted to admit a patient, they would click 2 buttons. The alerts would go to the inpatient physicians, and then the physicians would read that whole note. If there was any questions, they would have a direct conversation, but if there weren't any questions, they would just accept the patient would move up. The actual admission process for me as a physician in the emergency department is after 2 to 3 hours of figuring out what's going on with the patient, then I go to SmartWeb and put a page for them to call my secretary. The secretary then announces overhead that there's a phone call waiting for me, anywhere from 2 minutes to 30 minutes. I have no idea when I'm going to get a call back. I could miss that call. I'm not going to sit and wait for that call. The person who calls back gets frustrated because they miss me. Then they call back again. It can take anywhere from 30 minutes to an hour to get a hold of my consultant. At that point, I have to verbally present the patient to the consultant. They have to ask a lot of questions. They have to get to a computer. They have to pull up the patient's MRN on the computer. I'm sitting there while my nurse is asking me about this coding patient that's next door. I have to hang up the phone, go take care of the coding patient, then I have to go back to the page them again, then finally, after an hour, maybe admit the patient and then put in a bed request that then goes to the nurse supervisor that they have to clean a room, and then they go through there. It takes a little bit of time and effort.
This is why we're stuck there for so long.
Yeah, no, it is. It really is. All of that human conversation and designing of buttons to have someone call back can be really streamlined by some of the systems that I've seen have been created before. I think the opportunities for improvement in emergency medicine are information display, information entering, and clinical decision support. Those are the three things that emergency medicine would most benefit from.
So as a faculty member and then as a student,
Yeah.
are you going to, you work on sepsis thing,
Uh-huh.
but this issue of documentation, is that something you're going to try to address?
I think on low grade level, right now with my time, yes. Documentation is such a huge beast. I mean, it's almost impossible to tame, really. And we can do small clicks and text edits in the EMR that we have. What I would love eventually in my life is to be involved in the implementation process from the beginning and really see it from a physician entry emergency perspective. I think the emergency perspective in informatics is often lacking. But I can't do that right now. It's already implemented.
Well, an opportunity, I think, that some people have been involved with, the fire, we're having a fire, that first group, we want to have a lot of communication on. So there's a new standard called FIRE,
Okay.
and it helps you can build an app,
Uh-huh.
you can build a new documentation app, and it can plug into Epic, and it can pull data and visualize it, and you can enter data and you can put it back into Epic. So it's a way to not say, oh, I can only deal with what I have in Epic and Slips,
Yeah,
but you could really redesign something.
that's
And so
awesome.
they've done things like in rheumatology, redesigned it so that it pulled in data from disparate sources, showed all the important information on one screen.
Yeah.
Drew a picture of the person with all their joints, they cut in colors, they did the places where they got the information.
Yeah.
And they showed how it really improved care. I mean, that's possible, and our institution is investing in this.
Uh-huh.
With informatics and the IT group and the gap lab
Yeah.
and the library. And so if you want to go down that path, it's possible with your championship in emergency medicine that you can get partnership.
That's super cool. See, that's why I'm a student.
Yeah.
There's so much to learn.
Don't give up.
Yeah. Yeah. So.
Any other questions?